So I'm going to invite Dr. Niall Keenan, who is the East of England clinical lead for Virtual Hospital, but also a consultant cardiologist at Watford, to describe his vision both at national level but as local level for the virtual ward. So over to you.
Thank you, Stella, and thank you very much for the invitation. I'm delighted to be here, and also I'm delighted that there's a session about virtual wards in this meeting, because virtual wards are a really key answer to a lot of the problems we were hearing about in the first session. And so I'm basically going to give two short talks sandwiched together. I've been asked to talk about what the national picture is, the national vision for virtual wards, and then to talk about our local experience with virtual wards, where we run a nationally leading virtual ward in Hertfordshire. I didn't include any videos in my talk because, as we just saw, they can go very badly wrong. But here are two QR codes for two videos. So I would say for anyone who's feeling bored or doesn't know about virtual wards or doesn't want to listen to what I have to say, just take pictures of these two QR codes. And these are two very short videos, one from our own team and one from the team at Frimley. And they're really, really, really good videos, both about 5 or 7 minutes long, that will tell you almost everything you need to know about virtual wards. I'll show you the QR codes again at the end, but they're well worth watching and sharing with other people because there's a lot of people who say, what is a virtual ward? I guess a virtual ward, for anyone who's ever walked through a hospital and seen people sitting in bed and thinking, you don't look very ill, I wonder why you're sitting in this bed rather than being at home, virtual wards are the answer to that question, because I think we all know, especially people who work in hospitals, that there are very many patients sitting in hospital who are not critically ill, they're not in intensive care units, they're just sitting there, and a lot of what they're waiting for could be done outside hospital. So virtual wards are really the answer to that question, and that could be something very simple, like someone waiting for a blood test, or much more complicated things, like someone getting over an operation. There's a lot of confusion about this, so I'm just showing this. This is the national definition of virtual wards. Safe and alternative to NHS bedded care, in some countries called hospital at home. They support patients who would otherwise be in hospital. What that means is that they are not for people who are managing the waiting list, chronic disease management, primary care prevention, community podiatry, all of these things. Those are not virtual wards. So virtual wards, in the strict definition, are patients who would otherwise be in a physical bed in hospital, either through prevention of admission or early supported discharge. So a virtual ward needs to be a patient who would otherwise be in hospital. It says here, preventing avoidable admissions or supporting early discharge. These are the two paths of virtual hospital. There's a lot of talk, when we talk about virtual hospitals, about technology. I'm not going to show any proprietary stuff or there's a huge marketplace out there of people making all sorts of equipment that can be used for remote monitoring. That people say that there's hospital at home, broadly speaking, frailty, which is mostly face-to-face. A lot of this isn't particularly tech-enabled. It's to do with people going into your house and doing things to you. And then there's a lot of mostly remote, which is patients sitting at home with various devices transmitting numbers to the base back at hospital. But the key point really is virtual ward is not primarily about the technology, it's about the patient. And I know that sounds like a sort of buzz phrase, but it is true. You are not going to sort this problem out just by buying the right equipment. You need to identify which patients you're talking about, and you need the right staff. So technology is, however, a vitally important part of the vision, but it's not primary. Sometimes these talks are very much about the tech, which is important, but it's not by no means the whole picture. So it's best thought of, and we're talking about the National Long-Term Plan, as a sort of gradation here. So we're talking about here preventative care, interventions in the community to stop things happening to people, like stopping smoking, proactive care, anticipatory care, virtual ward, and hospital at home. Sometimes this is shown like a pyramid, but someone's done it this way. But anyway, so we're talking about virtual wards and hospital at home as a follow-on from anticipatory care. It's best thought of in this sort of gradation. Hospital at home is more intensive than virtual ward, because virtual ward is just mainly remote monitoring, whereas hospital at home is actually going into people's houses. Virtual wards have a potential to really change how we deliver care. And then this is another key point I want to make. This is not primarily about saving money. Saving money is important, and virtual wards are highly cost effective, but they are not just about doing things more cheaply, they are also about doing things better and in a way that's more acceptable to patients. Because I think as doctors or nurses, we're very comfortable with looking after patients in hospital. You know, we've got our ward, we've got our patients lined up, and that's what we like. But we sometimes forget patients would rather be at home, and people just say that. It is actually true. Patients really would rather be at home, and we should be empowered to do everything we can to deliver care in patient homes when it's safe and possible, rather than the slightly old-fashioned mentality of, you know, we've just got our 20 beds, we've got our patients lined up, and you know, we're going to see them once a day and take it forward like that. Okay. So, cost-effective, good outcomes, better, high levels of patient care and satisfaction, greener, because we don't have all the resources of the physical hospital, and a different range of pathways, and tech-enabled. These are the key aspects that we talk about. The national ambition is to get to 40 to 50 virtual beds per 100,000 population, which equates to 20,000 virtual beds. That is tracked very closely by the national team and also politicians. We're about halfway there yet at the moment, but there's about 10,000 virtual beds open. And the key numbers that NHS England quote are the number of virtual beds and the occupancy, which the target occupancy is about 80%. So think about what population you're looking after. So I know we're looking after about 500,000 patients, and we're meant to have about try and get towards 200 virtual beds. So 40 to 50 virtual beds per 100,000 population. The key mandated national pathways are ARI and frailty, acute respiratory infection, that is. But a lot of people have gone further, and I'm going to show some examples of what that looks like. Frailty is one of the first ones that people suggest implementing. It's actually one of the hardest to implement because it's the one that involves doing most in people's homes. So this is the full range. Stella and I were just talking about this, but there's pre-hospital admission avoidance. There's ED admission avoidance. That's quite difficult to do. You get a patient in ED and you say, no, we're not going to admit you to a physical bed. We're going to get you on board into the virtual hospital and get you home. Then you need a team there to go down and see the patient and do that. Early supported discharge, probably the easiest one to start with, where you just have your heart failure patients and you say, we're going to send you home a few days earlier and monitor you at home. Elective, there's a lot of interest in this, shortening inpatient lengths of stay for surgery, for example, by sending people home much earlier but using remote monitoring techniques. And, you know, day case hip and knee replacements are being discussed with this sort of technology. Trauma. End of life, I went on a visit to Spain to look at a healthcare system there where they do a lot of stuff in a very integrated way. I don't think they've got such a big hospice movement in Spain, but they end of life was probably about between a third and a half of all of their virtual ward patients, and palliative care. And other things that we're working on, children and young people, because there's loads of kids who are brought up to A&E to have antibiotics if there's query sepsis, or for monitoring of jaundice, all sorts of things like that, which could easily be done at home, very acceptable. Especially if you imagine someone who's just given birth being forced to bring a baby back, in the first week or two of life for repeated blood tests in hospital for jaundice. It's something which would much be better be done in the community with remote monitoring. And mental health, that's a particular challenge. This is just a slightly buzzier way of showing this, but showing that the range of things that people are talking about: infections, OPATs, COPD, end of life, heart failure, something we're particularly interested in. So these are the sorts of things that people are talking about, the sort of patient groups. Virtual wards are underpinned by a common clinical model, and this isn't rocket science. It basically means that you've got a senior clinician in charge, you've got the virtual ward, you've got the remote monitoring team working in the hospital, you've got the nurses in the hospital based in the hub and going and looking for patients on the ward to onboard, and you've got the community team, you're properly tied in to primary care, and you're linked in with the third sector as well. We've had a lot of work with the Red Cross in terms of helping with what we're doing. So the model is the same no matter what sort of pathway you're talking about. So here are some key principles. Early supported discharge or alternative to admission. The lead provider may be the acute or the community, and we've seen in the region that I'm involved with, East of England, we've got good examples of both. Integrating them is a challenge, and it's really important. Otherwise, you end up with a virtual ward purely run by the acute, where you don't have any community onboarding, or a virtual ward purely run by the community, which focuses on prevention of admission and doesn't have an early step down from the acute, so they need to be integrated even if there's a lead provider. Clinical responsibility sits with the lead provider. That's really important. GPs, in my experience, they're very happy for patients to be on board into virtual hospital as long as the virtual hospital completely takes over the patient's care. It doesn't work if it's trying to be done with the GP, where the virtual hospital team is tasking the GP with doing things all the time. They don't, that's not acceptable to them. So it has to be, the responsibility sits with the people running the virtual ward. Monitoring for people who would otherwise be in hospital. It's recommended to have your monitoring hub running 12 hours a day, 7 days a week. Out-of-hours provision means patients know what to do if they're unwell out of hours. It doesn't mean that you have to monitor you have your remote monitoring hub running 24/7, because very little actually happens at night. These are quite stable patients, and it's obviously extremely expensive to staff that. And we've got very well-established 111, 909 services, obviously, for patients who've got problems out of hours. Range of conditions. Technology enabled is part of the national mandate, and it is important. Empowering patients and carers. Implemented at ICS level, but locally adapted, so it's not a one-size-fits-all. The range of models across the country is extremely variable, and I think it does need to be slightly brought together. And I think the way I often approach that is to say that it's to do with equity of access, really, so that the same pathways should be available everywhere, even if the model's not the same. How you recognise people, what your escalation pathways are, time-specific, and they say that pathways up to 14 days. So that's why this isn't for, your CF population who you're giving antibiotics to for months and months and months. It's a focused intervention for 2 weeks. It doesn't matter if you go a bit over that, but it's not your, months of monitoring for heart failure or something like that. And fully integrated existing services. I'll just show you where a couple of people have gone with this. So this, for example, is from our colleagues in Mid and South Essex. So any patient there who phones NHS 111 999 GP or community, they immediately do a quick triage to say whether they think the patient should go to the physical hospital or the virtual hospital, and they are set up with the proper emergency community response to go into patients' houses and onboard them into the virtual hospital. So they really do think about it this way. And this is a slightly more developed diagram from the same group, but it just shows how they're really thinking about this single point of access, all the different community responders, and then where is the right place for this patient to be looked after. Okay, so that's the first half of what I wanted to say. I guess that's the national picture. And about 10 minutes in, I'm just going to now spend the next 10 minutes talking about our local experience. So this is a partnership. So I work for West Herts, which is West Hertfordshire Teaching Hospitals NHS Trust, but it's a partnership in the South and West Herts Health and Care Partnership, which is part of our ICS. The other people in this are CLCH, which stands for Central London Community Healthcare NHS Trust, is a community provider, GPs, primary care, and also third sector, as I mentioned, the Red Cross. So we were very early, I think, into the virtual hospital game, if I can put it that way, and we had a probably the first virtual hospital in the country for COVID, and that's really put us, I think, ahead, and that's why we've had a huge amount of interest in what we're doing. I'm just, this is just to give you an idea of what we've had going on. This is Matthew Knight, who set things up. Andy Barlow, our lead for respiratory, did a huge amount of work. We've had, I don't want any booze or anything, but we've had Secretary of State visiting, we've had David Sloman, we've had Oliver Dowden, we've had our local MPs, we've had TV, we've been Downing Street, all of these things. There's enormous interest in virtual wards. And you might say, why is there so much interest? And I think it's A, because it's very good for patients, and B, because people feel that this can be a way of trying to get us out of the hole that we've got into with surge, with unable to cope with A&E, because we can just decompress hospitals using virtual wards by moving a lot of the activity out into the community. So as I said, we started with COVID, and we launched in COPD and heart failure in December 21, and then last month we launched pneumonia. It's a system-wide collaborative project. We've put 771 patients through this program so far, and it's all tech-enabled. The objectives are not just to reduce length of stay and to reduce admissions to hospital, but also to improve clinical care. That's because this is my personal experience. It is much, much more joined up between the acute and the community now than it ever was through the virtual hospital, because we know the community nurses much better, we know the GPs much better. It is much, much more integrated. It's been a huge improvement, and it has improved outcomes and patient experience. And that's why I often say virtual hospital is about quality improvement as well as cost. So patients, either identified in the community or on the wards or in an emergency department. We have a virtual hospital monitoring hub. We have an onboarding team. If a patient's deemed suitable, they go and see the patient and they say, yes, you're a suitable patient for virtual ward. They give them all the equipment that they need. They explain to them what's involved, and then they send the patient home. Then their virtual hospital journey starts. The patient's sitting at home. They use the equipment every day, and basically it asks you, how are you feeling today? Are you feeling breathless? You answer all the questions, which then get sent into the hub. You then do your observations, which then get sent into the hub, and then we have a virtual ward round where specialist nurse or doctor speaks to you every day, and then we decide what's needed. And that might be changing your heart failure medication. It might be the community COPD nurse needs to visit you at home. It might be we need to bring you back to the hospital to have a look at you. And we keep patients in the virtual ward for between, I would say 3 to 10 days on average. And it's a much softer landing in the community than for people who have done early supportive discharge. We can give people IV furosemide in the home. There's so much you can do. There's MDTs, of course, and patients supported by, we refer all patients to the voluntary sector. These are just some examples of the kit we use. Digital exclusion is really important. So if someone doesn't have a smartphone, we give them a tablet so that there's no one is excluded from this by not having, it's not a service for only people who've got iPhones, in other words. And this is a home ECG, continuous saturation monitor called Radius PPG, blood pressure machine, Bluetooth scales, surprisingly difficult to use. These are just some of our pathways. I'm just going to slightly accelerate a bit. It just shows you what they look like. So if you imagine that this is a conventional stay in hospital, this is what it looks like. You're in the physical ward, then you go home. So actually, this line is meant to be longer than this line. So you're in touch with the healthcare system for longer than you would be than if you just went home. And because of the visits at home and the contact with the hospital, it is not this. Some patients describe going home from hospital a bit like going over a cliff edge. You're being seen, constantly in hospital, and then suddenly you might get an appointment in 3 months' time or whatever. So it's a much, much smoother and softer landing in the community for the patients, and that's why one of the major challenges in virtual hospital is offboarding patients, so that patients really, really like virtual hospital. And if you say, we've come to the end of the 2 weeks and I think, you're doing fine now, we can transfer your care back to primary care, patients often, I'm not saying they're crying on the phone, but they don't want to give up the contact because they value it so much. These are our key outcome data. So for the 381 patients who've been through the heart failure pathway, the average length of stay this is early supported discharge, the average length of stay in hospital is 5.7 days for people who we put through the pathway, whereas other patients who've not gone into the pathway have an average length of stay of 9 days. So we've basically taken a third off the length of stay in hospital. There's no signal for safety and there's no increase in readmissions. And I just show this age and NT-proBNP, and for COPD, a similar number of patients, similar reduction in inpatient length of stay. The reason I'm showing this is just to show that these are not, it's not like we're cherry picking, a handful of younger, really, really fit patients. It is all comers, and they do match, the population we're putting through this match the population who we're not putting through this just because for some reason they've not been referred to us. And we've considered that in different ways. If you look at, this is our Academic Health Science Network evaluation of our COPD pathway, and they've matched our patients in the virtual hospital and not in the virtual hospital by Rockwood, by various markers of COPD, home oxygen percentage, and that they are the same. So it is a real difference. It's not just an artifact. The death rate at 30 days, this is about safety, is about 2.5%. That compares with a 6.3% 30-day death rate for all comers for COPD and an in-hospital heart failure death rate for 9.3%. So it's actually a lot less. I'm not saying that virtual hospital is making people live longer, but it's certainly not, because what people worry about is the death rate will be higher because your patient is not, in sight, but in the community. And the same thing about readmissions. So it would be nice if the readmissions were lower for patients in virtual hospital, but people are interested in readmissions because the idea was the readmission rate will go up because, you've kicked the patient out of hospital too soon, and so therefore, they're not stable at home, and therefore they're going to come back in. And our data shows that there's certainly no signal that there's more readmissions for people who put through virtual hospital, and there's some data that suggests actually people are coming fewer readmissions because they're getting much better care. It's highly acceptable to patients. The average score for feedback is 9 out of 10 of these, for heart failure and 8.4 for COPD, so that's 700 patients. So we never normally see scores this high. for feedback. And I think it's really remarkable how acceptable it is to patients. The vast majority of patients, when asked, did you feel safe, certainly did feel safe. So to conclude this bit about our project, I would say it's a highly effective launch. It is a highly effective intervention. The clinical model clearly works. It's clearly safe. It does have a significant impact of length of stay. It is a challenge to get the patients. You have to sort of actually have people going out into the wards and finding these patients. The patient relative feedback is truly excellent. We've seen, this is anecdotal, but with some data, really significant improvement in the quality of care. As I've said, softer landing in the community. You've got a bit more time to do more things to people because the whole length is a bit longer. So you've got more time to increase their heart failure therapies, for example, which is something that you can, which reduces readmissions. You're much better integrated with the community. So these things are much better. And then my final conclusion is, this is a spectacular national initiative. It's something that Britain can be very, very proud of. I think NHS England can be very proud of this. They've started really from zero, and we've got to 100,000 patients have been through these pathways. So, it is absolutely fantastic. There are challenges, of course there are. Staffing, funding. Now, the funding was ring-fenced for this in the 22-23, but it's now been unring-fenced, and it's part of the urgent and emergency care budget. And I think people who run these virtual wards are worried that someone will just splurge the money on more surge capacity or something like that, rather than putting the money into interventions like this, which can really, really make a difference. There is an inherited conservatism with a small c in many, I think, hospital doctors in particular need to be able to willing to change clinical models, willingness to do things differently. And as we were hearing from Saffron earlier on, engagement of a fatigued workforce. But I don't think Einstein really said this, but I think this is such a good quote about insanity is doing the same thing over and over again, expecting different results. That is a bit like where we are with urgent and emergency care. We do need to do something differently if we're going to really deliver change. So thank you very much for your attention. Those are the videos again.